Hi, my name is Demi Moses, and I'm going to be presenting today on yoga-based interventions for cancer-related cognitive changes in breast cancer patients. My doctoral experience was really unique and rewarding. I was able to immerse myself in a lot of different aspects of the care continuum. The majority of my experience at the Breast Cancer Treatment Center was comprised of site-related projects, patient care experiences, and continuing education opportunities. I participated in educational lectures and workshops to further my knowledge on emerging and evidence-based treatments in oncology care. I collaborated interprofessionally and was able to advocate for the role of OT across different cancer-related conditions. For example, I presented to a neuropsychologist to articulate the role of OT for functional cognition and encourage more referrals between our two disciplines. A goal I really had for myself for this doctoral experience was to see the patient perspective of their care experience through many different lenses, not just the lens of the healthcare provider, because I felt that would really better myself as a holistic and client-centered occupational therapist in my future practice if I can understand and learn more about how a patient receives and interprets their own care experience. Through the many different treatment, shadowing, and collaboration opportunities that are listed here in the middle section of my poster, I really feel like I was able to accomplish this goal and really developed a in-depth perception of the oncology care continuum. My individual research and experience focused on cancer-related cognitive dysfunction, which is a common and highly reported side effect of cancer treatment, yet the literature is limited regarding specific etiology and treatment options. On the left is a brief summary of my systematic review in the available literature on yoga and mindfulness interventions for this kind of cancer-related cognitive change. One of the most prominent and reoccurring components of these studies ended up being the mindfulness-based stress reduction protocol, which is a program by Jon Kabat-Zinn, and it was actually mentioned in 7 of these studies, so it became the foundation for my project and case study. If you look to the right, you'll see more information on that in this chart in blue will provide you a detailed structure of what my protocol looked like. I extracted relevant and feasible components from the MBSR standards of practice and combined them into 4 weekly sessions designed to be easily integrated into OT treatment. So the sessions included a cognitive functional activity, a mindfulness-based intervention from the MBSR, a yoga sequence that was extracted from an Ohio State study. The protocol was created by Marcia Miller of Yoga on High for breast cancer survivors, and home programming, which was an important component of both my program and MBSR. The cognitive tasks included med management, weekly calendar planning, but this can be really individualized for a client. The mindfulness exercises from MBSR included meditation, body scan, deep breathing, walking meditation, and I selected these based on patient interest, feasibility, and their overall occurrence throughout MBSR. I was able to implement this design protocol with a patient at my site. She had a diagnosis of left breast cancer. Upon beginning the program, I administered the Attentional Function Index, which I extracted from one of the studies in my review. It's a self-report measure. My patient attended 3 out of these 4 weekly sessions, and this difficulty with attendance is a frequent barrier to outpatient therapy settings. But consistent with the literature that I found, my patient reported that the mindfulness strategies were very beneficial and enjoyable. She liked participating in them, and she felt that they helped her overall stress levels and helped her handle difficult cognitive tasks. Her overall goal for treatment was to return to work, and she felt that she was able to implement these strategies successfully. I think it's also important to note here that cognitive functioning is a mix of different comorbidities, such as this patient had anxiety, depression, fatigue. So it's important to consider all these things when assessing and treating cognitive functioning of this population. But her experience really mirrored what was found in the literature, as well as she demonstrated a 41-point improvement of self-perceived cognitive functioning. So overall, my project and experience supports yoga and mindfulness as emerging strategies for OT practice in the treatment of cancer-related cognitive changes. And to the left is a brief concept map diagram to better understand the continuum, what cognitive change looks like in this population, deficits in memory and attention and executive functioning, some of the comorbidities that I mentioned and different risk factors with oncology and treatment. It was a great experience, and I'm excited to continue with evidence-based treatment in my future. A couple questions. What is unique about the oncology population to consider when treating these patients? I briefly touched on it, but it was challenging in the oncology population to consider the various and the number of comorbid conditions they experience as a result of disease progression or the cancer treatment itself, such as chemoradiation. So I would go from treating an orthopedic injury, such as carpal tunnel and rotator cuff, to fatigue, to neuropathy, to cognition, and they all interplay off of each other. So you can never piece one out, but it's important to identify priority to the patient as well as your priorities for treatment. But it was interesting and exciting to be able to treat complex people in complex lives and improve their functional performance in many ways. What would I change after my program was implemented? One successful component was the engagement of the participant's sister throughout the program. She was very beneficial for improving patient motivation and home participation. So I think one thing I would change would be a more emphasis on caregiver education. I would also stress the ability to individualize this program for your specific client and using a functional cognitive task that is relevant to them, such as a work-related task or something they have difficulty with, and it can really vary from person to person to be the most effective. And some of these strategies like yoga and deep breathing for reducing stress and helping with mood can also be beneficial for a caregiver to reduce their stress levels and potential caregiver burden. So I think that's another important consideration. Lastly, how was I able to assess cognitive performance and measure improvement effectively? A barrier throughout this process was the lack of a standardized objective cognitive assessment in the literature, and they were mostly self-report. I had to extract different cognitive domains, and many of these assessments were very extensive and not feasible for outpatient. I chose the AFI because it was short and feasible for the outpatient setting, and it did demonstrate sensitivity with this population. I was able to incorporate the weekly calendar planning activity, WCPA, which is an objective assessment. Although I was unable to formally administer it, I could use it in conjunction with my own clinical judgment and observation to assess cognitive functioning. Even though I did end up relying a lot on what the patient reported, if she felt she was functioning better, I think that's a very important consideration when interpreting results, and how much she enjoyed and felt the program was beneficial.